Good morning, everyone. Thank you all for joining us for today's convening addressing the unaffordability of health and long-term care for California's middle-income adults, co-hosted by the SCAN Foundation and West Health. My name is Emily Cosillo, and I am the Director of Programs for Insure the Uninsured Project, or ITUP. We are delighted to be able to facilitate this conversation today. Before the session begins, I have some important housekeeping notes for you all. First off, this webinar is being recorded and will be available on the ITUP's event page. Attendees can listen to this webinar through their computers or by dialing in using the number and passcode provided by the Zoom software. You are also welcome to utilize the closed captioning function. Just click on the CC button on the bottom of your screen to enable the live transcription feature. Today's webinar will run approximately 2 hours and will have 3 main panels, each followed by a question and answer session. If you have questions during the webinar, you don't have to wait until the end of each panel or presentation to submit. We encourage you to submit your questions using the question and answer panel, which you can also find at the bottom of your screen. When submitting a question, please indicate if it's directed at a specific speaker. We will answer as many questions as we can throughout today's webinar. Also located at the bottom of your screen is the chat panel. Please feel free to use this chat function to say hello or chat with other attendees. We will be posting relevant information and links throughout the webinar here. And now, with that, I'll hand it over to ITUP's Executive Director, Katie Hydorn, to get us started. Katie?
Hi, Emily. Thanks so much. And hi, everyone who's listening. Thank you so much for joining us. As Emily said, I'm Katie Hydorn, Executive Director of Insure the Uninsured Project, or ITUP. And we're very excited for this conversation today and really grateful for the partnership with the SCAN Health Foundation and West Health. So thank you for joining us today. And it's my pleasure to introduce Dr. Sarita Mohanty, who's the President and CEO of the SCAN Foundation, and Tim Lash, who's the President of West Health, for some opening comments. Sarita, I'll go to you first. Thanks for joining us this morning.
Thank you so much, Katie, and to the entire ITUP team for organizing today's important discussion. And also, I'm really excited to see the esteemed panels that you have put together, so thank you. We really want all older adults to have the services and care they need and an ever-expanding set of choices to age well in home and in community. And at the foundation, the SCAN Foundation, we emphasize several priority populations. And one of those is the forgotten middle population. This is a segment of U.S. older adults who don't qualify for Medicaid or Medi-Cal here in California and lack the resources to pay for housing and long-term care. And they are distinct from that population above that do have the resources to pay for private care and or private long-term care insurance. So today's discussion, I think, really highlights the experiences of these middle-income older adults and jumpstarts this call to action to build solutions to help this growing segment of our state. You know, there are a few key statistics that I'd like to highlight. One is that over the next decade, the number of middle-income older adults nationally will almost double, reaching 16 million adults aged 75 or older by 2033. And in California, this population will grow by 60% to 1.6 million. California's middle-income seniors also are becoming more racially and ethnically diverse. People of color will make up nearly 50% of the state's middle-income population by 2033. So I think we need to ask ourselves a critical question. Do we have culturally competent programs and services in place to support people with more diverse experiences and needs? And I think at this point, we would agree that the answer is likely no. And so it is now time, we do need to act. This latest research from NORC also shows that even if California's middle-income older adults sold their homes, which most do not want to do, half could still not afford to pay for private assisted living. So we know that most older adults want to remain in their homes as they age and expect to receive the support and services they need at home and in their familiar community. And at the national level, the Build Back Better Act included support for home and community-based services, but the Inflation Reduction Act, the legislation that was eventually passed just this past August, did not include this level of investment. So we need national solutions, but in the meantime, let's discuss how to address this crisis for our older Californians. So I want to close by sincerely thanking our co-funder and partner in this work, West Health, for their leadership in elevating the need to better support the health and well-being of middle-income older adults. And I really firmly believe together, we do hope that today's presentation sheds light on the forgotten middle here in California and nationally, and really starts a meaningful discussion and helps produce new and needed solutions for middle-income older adults. So really appreciate the time. And with that, I will turn it over now to Tim Lesh. Thank you.
Great. Thanks, Sarita, and thanks, Katie. And it is a true pleasure to be partnering with SCAN and ITUP on this. We too at West Health, get up every day thinking about how older adults can get access to, the services they need more broadly than just medical, in a place, a setting that's appropriate for them, and in a way that preserves their dignity. And you can have all of those things, but you can have a fabulously expensive system, and then it's ultimately useless because people don't have access to it. And I think what I'm most excited about this discussion, as we frame it around sort of broadly the forgotten middle, is that I know the panelists are going to lean into the many facets that define that. And I think all too often in healthcare, we end up having siloed discussions. I was on a call just the other day when we were talking about how I think it's 37% of health systems now are projected to be operating in the red. And some on that call were like, wow, that's really tragic. But you have to push that up against the corollary, which is we spend more in the United States on healthcare than any other developed nation. So, and there's lots of profit that's out there. So if you just look at it through they're losing money, you're missing a bigger picture because we're spending a ton. So if you can't figure out how to operate in the black when we spend more than any other developed country, there's a problem, but you don't see the problem until you start to connect it together. And I think, there too, lies some of the challenges as we think about, policy and advancing sort of models for the population that we're talking about, right? And, even at the surface, when we say the forgotten middle, and we're going to dive much deeper into it, it's easy to think about income, right? And say, okay, so we're talking about a group they're not poor, they might be near poor, they might be slightly above, they're certainly not rich, but we're talking about their finances. So, their access to healthcare and other things, it's about the finances. The reality of that is it's simply not true. We did a study ahead of the Medicare Negotiation Act in the IRA that looked at non-adherence in the Medicare population due to cost for prescription drugs. So lots of reasons you might not take a drug, but just due to cost. And there's over 100,000 lives that are lost every year because people can't afford their medication. So when we talk about this group of vulnerable population that might be above a level that that doesn't qualify for some of the more robust safety net measures, but certainly doesn't have the means, to protect themselves and their families in the way that they do. We're not just talking about finances. We're talking about life itself, and I think that's really important to understand and embrace as we think about what the policy solutions might be and how we approach it. I think there's another misnomer again because we talk in silos. It is very true that many of these families are one event away. Whether it's a very catastrophic diagnosis or the need for institutional care or an onset of Alzheimer's that can paralyze not only the individual but their loved ones and their families from an economic standpoint in terms of how they're going to access that. But it's also true when you look at sort of this broader population that their ongoing medical expenses, which are related to their ability to pay for these things, can also be quite paralyzing. And in a recent Gallup study that we did, roughly 40% of those over 65, reported, and these are on Medicare, that they really struggle and have concerns about their ability to pay for healthcare. And let's not forget that, again, we all work in healthcare, but that's just one piece of what people prioritize, right? There's lots of, aspects of one's life and investment and, values that are important to an individual, to their family, their ability to engage meaningfully in the social fabric for which they desire to engage in. And again, there too is an example of we tend to focus just on one aspect. It's healthcare costs or it's the catastrophic, but there are also these ongoing expenses, and inflation is like the fuel on the fire that's just making that worse. I'm optimistic in California. We've made some recent changes in terms of where we define the federal poverty level and some protections on asset spend down that will be a necessary but ultimately insufficient step forward. But what is the most necessary is that we start to engage, I think, in a very holistic discussion, around, what is it that, these individuals, their loved ones, their families are facing in this forgotten middle group. And then, just as we do, hopefully, on healthcare, think 360, right, around, sort of what are all the not only the medical, but the social and psychological needs of an individual, their community needs, as we think about the solutions for this population, that we think about all of the pressures that they're under, because they deserve a path that, that protects them and that doesn't sort of bind them to decisions that no one should have to make, to trade-offs that no one should have to make. And I know the panelists are going to cover this in great detail with great data. And with that, Katie, I'll turn it over to you, but really appreciate the partnership and very excited to be part of this.
Tim, Sarita, thank you so much for the opening comments. And I know we're really excited to get started. So thank you both for your support, for lifting up this really important topic and really important group of people. So thank you so much. I'll invite you to turn your videos off and we'll get started. So it's really my distinct pleasure to turn this over to Caroline Pearson, who is Senior Vice President, Healthcare Strategy at NORC at the University of Chicago. She has some very important data to share with us about California's specific forgotten middle population. And but Caroline, before we get to you, we want to know how much our audience actually does know about the forgotten middle before you tell us all about it and define it for us and share your data. So I'm going to invite Emily to share a quick poll for you. If you could all take this, this is, I think, really important. It'll be really fun to see how much you all know about it now and how much after Caroline's presentation and our wonderful reactor panel, at the end of this. So we'll give you just 30 seconds to take it and then we'll move on. All right, Emily, thank you so much for sharing that. And Caroline, turning it over to you. Please go ahead and share your screen.
Fantastic. Thanks so much, everybody. I am delighted to be with you today and to be able to share these important results with you. So as you've heard, we want to talk today about a group that we call the forgotten middle income older adults. And this is work that the team and I at NORC started on actually around 2017. And we released in 2019 the very first forgotten middle study, which was the first time that anyone had really looked at this population nationally and defined the size, the demographics, the health needs, and the financial resources of middle income older adults. And then what we did is really projected forward 10 years into the future to understand what the needs of those adults were going to be in 2029, because as we identify problems, we always want to look ahead and so that we actually have time to prepare and respond. That work was some of the most impactful work that I have done in my career, and it was really impressive to hear everybody's strong reactions to that research when folks really said, wait, we really don't have a systematic long-term care plan for middle-income adults. Like, I think I might fit into that group. And so we have refreshed that work, and we recently released new data, which I'll share with you now, forecasting nationally to 2033, and really trying to sort of understand as more of the baby boomers age into that 75 and above group, what their needs are going to look like. And as you heard from both Sarita and Tim, one of the reasons that we're focusing on middle income older adults, which is a different group than a lot of attention typically is centered around low income adults. But we focused on middle income because in some ways, when we speak about long-term care, they have some of the fewest options available in terms of paid caregiving and housing options. High income individuals have a whole market of private pay affordable options available to them. Low-income individuals may qualify for Medicaid or Medi-Cal in the state of California and have access to covered long-term care services. But the middle-income group sort of falls in between. And so when we did the analysis nationally, we sort of set these lower bounds conservatively to try to exclude anyone who might be eligible for Medicaid nationwide. And so you see the groups running from about $25,000 a year anywhere to almost $100,000 a year for that oldest cohort. And that's a combination of income as well as assets annuitized over the expected lifespan. And what we found in that research is that looking ahead 10 years into the future, the size of the middle income population of older adults is going to nearly double. There'll be about 16 million of them in 2033. And while not all of them will need additional health and caregiving support, some will. We see that many of them have health needs, have mobility limitations, and have cognitive impairments that may impact their ability to live independently, and potentially for some of them, their ability to remain in their homes. And so one of the things that we wanted to look at was really if folks decided that they couldn't remain in their homes and that they needed to move into an assisted living facility, do they have sufficient financial resources to pay for a private pay assisted living? And in this case, 3/4 of middle income seniors are unlikely to have sufficient resources to pay for private assisted living. So 11.5 million older adults who, if they need it, are really sort of without any of those private pay options. Of course, there are many options for long-term care, including in-home solutions. And so I'll show you some more of those options as we get into our discussion today. So the way that we did this work was really relying on the Health and Retirement Survey study and then projecting forward into the future. But as we present these results nationally, one of the things that we hear when we visit California is these numbers simply don't make sense here. California is such a different market in many ways, including that it is significantly more racially and ethnically diverse than the rest of the country. We see, interestingly, a different educational distribution in California. So more individuals earn, more individuals that are going to be older have no high school education, didn't finish their high school education, but we also have more with a college degree. So it's sort of a more polarized educational landscape. And we know that education is one of the key variables that affects people's financial stability and their savings long term. We also see that in California, older adults are less likely to have children living within 10 miles of their home. And in addition to spouses, adult children are one of the important sources of familial caregiving for many seniors. And then lastly, as you all know very well, California is an expensive market. And so on the right-hand side of this slide, you see some of the differences. This is percent differences between long-term care costs in California relative to the national average. And so you can see here, assisted living facilities are about 17% more expensive in California than the rest of the country. Nursing home private rooms up to 35% as expensive. And even things like home health aides and personal care services are considerably more expensive here. And that matters a lot when we think about how many financial resources older adults are going to need in order to be able to pay for this care. So as we go into this analysis, what we have done is taken our national model, again, using the Health and Retirement Study, and we have recalibrated it to be specific to the demographics of seniors who reside in California. And so the first part of my presentation is going to be showing you how those California results compare to the rest of the country. The second thing that we're going to do is talk a bit about California-specific programs. So we know that Medi-Cal in California has specific eligibility requirements. And so we're going to look at some of the sort of near dual eligible population to understand how public policy changes in Medi-Cal might affect some of these sort of near duals by expanding coverage today. And then I'll show you a few illustrative case studies to really help bring together Tim's point on how it is really the combination of individuals' family situation, their health needs, and their financial resources to determine what their sort of overall experience and options are going to be as they age. So diving in, here are the results for California. So this is the number of seniors who we expect to be 75 and above in the state of California. Starting in 2018, we think that there are about 1 million, and that will rise to about 1.6 million older adults in California by 2033. I will also point out that we see more than a doubling of older adults age 85 plus. And while anyone 75 and above may begin to need additional caregiving and health supports, we know that once individuals turn 85, they are much more likely to need additional caregiving and may not be able to live completely independently. So that's a really important group. And here is what the composition of those older adults, middle-income older adults, look like from a race and ethnicity point of view. And so I said, even today in 2018, or with the 2018 data, which is the most recent available, we already see that California is much more racially and ethnically diverse than the rest of the country, with a significant 20% of older adults today, middle-income older adults being Hispanic. That next group, that other, is predominantly comprised of Asian Americans, and then about 4% Black seniors. And that's going to grow to be 47% of middle-income older adults will be people of color by 2033 in California. And when I present this data, often people say things to me like, lots of these folks may not have health needs. They may not need assisted living. And that is certainly true, and certainly something that we hope for many of them. But when you begin to look at the data, you do see that a considerable number of these older adults are expected to have mobility limitations, a majority of them, more than 3 chronic conditions. And the way that's defined in the Health and Retirement Study means that's about half of all the chronic conditions that they track. So that's a sort of considerable medical need. And then we see that 21% have cognitive impairments, which is another challenge that often makes it hard for folks to live independently. And so these numbers suggest that at least a subset of these seniors are likely to need some sort of additional care or support. So, of course, first line of defense is always the family. And so we want to understand how the composition of families is going to be changing over time. And so one of the things here on the left-hand side, when you look at Californians over 75 from 2018 to 2033, we see that fewer of them will be married in future years. And this is largely due to just some of the demographic differences between marriage patterns and divorce patterns in the baby boom population. But that's a 10 percentage point decrease in terms of those who are expected to be married and still have a living spouse. And that is really going to affect, at the very first moment, sort of available familial caregivers, with the spouses providing a lot of that care frequently. On the right-hand side, we then layer in children, and we see that in California, 43% of middle-income seniors do not have children living nearby. And so those, again, are going to be folks that really don't have many unpaid options to rely upon. So if I have persuaded you that some of those older adults are likely to need additional support, and that they may not have the option to depend on family members for that support, let's understand what their financial resources look like. So here we take middle-income California seniors, and we distribute them just into quintiles to give you a sense of how their resources are comprised. And you see that income is the biggest source of financial resource, with most of these folks having incomes between about $30,000 a year and $45,000 a year. And then they do, have a small amount of savings in terms of assets, and that may include things like 401k savings, ranging again from about $4,000 up to about $24,000 of assets that could be used on an annuitized basis annually. And then we'll talk about housing, but aside from that fifth group, you see, relatively modest amount of housing equity, but certainly something that is relevant in that highest quintile. So when we think about, again, taking assisted living as one example, what proportion of seniors are likely to have resources that would enable them to pay for private assisted living in California, we need to start with the notion of how much is that going to cost. So we estimate that assisted living rent plus annual medical expenses in terms of out-of-pocket costs and premiums for Medicare generally is about $75,000 per year in California. And so when we apply that $75,000 threshold to the distribution of middle income seniors, we see that 89%, 1.4 million California middle income seniors are not likely to have enough financial resources to pay for assisted living, assuming that they do not sell their home. Now, assuming they do not sell their home is a major caveat, but it is one that's important to understand. In some cases, individuals may have a spouse who's actually still living in the home or kids that are living in the home, so the home may not be available to become part of their financial resources. We also know that many families try to keep their home as their nest egg. While my model can predict folks' mortality perfectly, we know that in real life, people don't know when they're going to pass, and so they want to make sure they've got a bit of extra cushion and sort of that insurance policy against unforeseen events. But in the event that we do have seniors that are able to use their home equity to contribute to their long-term care costs, we still have half of middle income seniors, almost 800,000, who would not be able to afford that assisted living rent on an annual basis. So shifting gears a bit here, I now want to talk for a moment about near dual eligibles. And again, we've been talking preliminarily in the forgotten middle about people who are not likely to qualify for Medi-Cal. But we do know that the real solution here for many individuals is that they delay care. And then as health deteriorates and at the point that they may qualify or need nursing home care, they then deplete their financial resources and qualify for Medi-Cal. So we wanted to look at what proportion of older adults is in this near dual eligible category. And so we were specifically looking in this part of the analysis only at income as a financial resource, because that is what is going to be used to determine Medi-Cal eligibility. And so for this piece of the analysis, we looked specifically at individuals with incomes between 139% of the federal poverty level and 400% of the federal poverty level. And these are the folks that, if they begin to have significant healthcare needs, might be sort of at risk for spending down to Medi-Cal. When we look at it this way, we see that by 2033, there are estimated to be still 1 million seniors in California falling into that near dual eligible category. And again, about more than a third of them are going to be over age 85, so folks with pretty significant health needs. And then on the right-hand side, you can see how that group is distributed by FPL level, so that as policy solutions are being considered, you can think about sort of how many folks might become eligible if we expand it, if we did some sort of expansion to 200%, up to 250%, et cetera. So that is what you can see here on the right-hand side. And then again, you can sort of see here the real important role that taking care of the near dual population plays in terms of health equity. And so, we look on the left-hand side at seniors who are likely to be eligible for Medi-Cal today. And they're, more than their majority people of color. But when we look at this near dual group, it's about 45% people of color. And again, we do see that many of these individuals have mobility limitations, a majority have mobility limitations, and chronic conditions. And as I mentioned, some of these challenges become much more severe once people turn 85. So I'll draw your attention to the mobility limitations, which jump from 50% of the population in 75 to 84-year-old cohort, but then up to 67%, 2/3 of folks over age 85. And similarly, rates of cognitive impairment more than double when we look at that older population. So let me show you sort of how all these pieces come together in a few illustrative case studies. And then I will pause and I'll open it up for questions. So data's great. Some of us, like me, really adore data and love looking at all those graphs and find them very compelling. But if you're someone who really responds to a human story, what we've done is we've drawn some actual sample respondents from the health and retirement study. So these are real case studies constructed based on real individual respondents. And then we have looked at sort of, we've completed a picture of them to give you a better sense of what their total experience is, what their family situation is, and what sorts of care they might need and how affordable it would be. Oh, and I'll point out, I'm only going to go through a couple of these examples today, but as we share this slide presentation this week, you'll be able to see that there are, in fact, 5 case studies, each of which have a bit of a different angle and a little more detail to reveal to us. So first, I'd like to tell you about Maria. Maria is a college graduate. She is married. And in 2018, when she responded to the survey, she was 61 years old. By 2033, she'll be 76 years old. And she is expected to still be married. Her husband here will be 88 years old in 2033. And she is living in the home, in her children's home or with her children. But at the point that we get to 2033, we project that Maria is likely to be experiencing declines in cognitive function, and she'll have been diagnosed with dementia. Her children, who do live with her, work full-time and are not able to take care of her throughout the day. Her husband has several chronic conditions and some challenges with activities of daily living, and so he's not able to provide the kind of care that they think that Maria is going to need as her dementia progresses. While Maria had low reported medical costs in 2018, we project that those costs will begin to rise modestly, although one of the things that we see with dementia is often that though folks may have dementia problems, they may be otherwise physically healthy. And so we see Maria has an estimated out-of-pocket medical spending of about $1,400 per year. So that leaves her with, after we remove her expected medical expenses, that leaves her just shy of about $80,000 in annual financial resources to pay for additional long-term care needs. That sounds like a decent budget that should be able to provide a good amount of coverage, but as I mentioned, California is an expensive market. So if Maria were to live in El Centro, she could hire a full-time personal care, pay for full-time personal care services for about $39,000 a year, which would only be about half of her financial resources. However, in the San Francisco area, that cost goes up to $78,000 per year and would deplete almost all of her financial resources. If the family decided that it was challenging for Maria to remain in the home and that ultimately they needed to move her into an assisted living to support some of her memory care needs, then interestingly, the costs between El Centro and San Francisco become more similar, and we're looking at about $70,000 a year in annual rent for the assisted living facility. Maria is estimated to have enough resources to pay for it, but that would be really stretching almost all of her lasting resources. Challenging decisions to make. Now let me introduce you to Glenn. So Glenn was in 2018, was 66 years old. He'll be 81 in 2033. And he's widowed. He does not have any children living nearby, and he does not own his home. He had some mobility limitations in 2018, but his health continues to deteriorate, and he really needs support with activities of daily living by the time 2033 rolls around. His medical expenses are increasing. He does not have supplemental coverage. And so his out-of-pocket medical expenses before premiums are about $2,000 a year. While Glenn is doing okay, he simply doesn't have anyone to provide caregiving support to him. And he only has annual financial resources of about $35,000 a year after paying for his medical expenses. So if Glenn were to need a home health aide to support his activities of daily living needs, he would not be able to afford that in either Redding or Santa Cruz. He would fall short by more than $40,000 in each of those areas. Similarly, if he wanted to look into assisted living, that would be about $50,000 per year in rent in Redding, $63,000 in rent per year in the Santa Cruz area, and he wouldn't have sufficient resources to pay for either of those. So Glenn is, I think, a good example of what we're describing, which is someone who has a reasonable number of annual resources to support his long-term care needs, but not enough to pay for the kind of care that he's likely to benefit from, at least in the California market. And so he's likely to either go without the care that he needs or potentially get by with a much reduced set of support. So with that, I am going to pause. I will stop sharing the screen, and I would love to answer any questions that folks have about the data before we go on to the panel.
Hi, everyone. Let's see, we've got a couple questions in the Q&A box, but if you'd like a question, we're not monitoring the chat box for questions, we're monitoring the Q&A box for questions. So if you have questions for Caroline, please go ahead and put them in there, and we will take a little bit of time. I think we've got about 6 or 7 minutes for some questions. So let's see, so first question, what impact will the elimination of the Medi-Cal asset test have on this finding of spend down risk?
Yeah, so we were trying to be thoughtful about that. I mean, as Medicaid folks, I think many of us were excited to see California and many states that would eliminate the asset test. But if you think about that quintile bar graph that I showed earlier, what you see is actually many of the middle income seniors are really relying on income as their primary source of financial resource. So, there is a sort of small set of individuals who have a lot of housing equity, but in fact, most don't. And so I think, the income levels still make them at risk of spend down, particularly as medical expenses and caregiving needs begin to outstrip those annual income amounts.
Thanks, Caroline. Another question, health plans don't typically collect income information. What are some other indicators plans can use to identify those near duals and outreach to those members to make sure that they're supported?
That is such an interesting question. Yes, we know that health plans do not have income information. It's actually one of the challenges as researchers. I think that this potentially ties into all of the discussion that we've had around greater awareness on social determinants of health. And there's been lots of work on, what are the most important social determinants of health and how do we begin to screen for those? But as we think about an older adult population, I think beginning to find ways to collect information about familial status, right, on sources of unpaid caregiving, as well as potentially, do you own your home? Do you have a sort of where can you live? Because we know place is going to be very important to both cost and sort of long-term affordability. And then, lastly, maybe we should be either collecting income or sort of collecting some sort of proxy for income. And I think that's probably a very, we need to be very careful. There's good reason that health plans don't have that. But as we begin to think about folks who may, for instance, as we said with Glenn, right, who may be getting by with less support than they really need, what that's going to cause is just a ongoing deterioration of health, right, and sort of risk if he's trying to live on his own in a way that isn't going to be safe and best for his care. So I think that I don't have an easy answer, but I think it's really important. And I think as we begin to collect data on a broader set of individuals' needs, we need to be thinking about these sorts of spend down discussions.
Yeah, thank you, Caroline. Another interesting question here talking about the high cost of living. Is there a trend of elderly immigrants moving back to their home country after retirement because of high cost of living?
I don't have an answer to that. It's interesting tracking movement in and out. And I actually think the census may have done a little bit of analysis on this retrospectively recently. I saw some migration pattern analysis, but migration patterns is one of the hardest things to track. And it is so population specific, right? I mean, we hear a lot about, and when I give this presentation, people say, assisted living isn't $65,000 a year or $75,000 a year everywhere in the country. Just like move to Ohio, and it's a cheap market there. But not everybody wants to do that. Not everybody can afford to do that. Not everybody's interested in leaving their family, their friends, their social networks. So I can't answer the specific question on immigration or immigration, but I do think that folks' ability to move, both based on their health needs and on their financial status, is just so person and so sort of population specific that it's hard to generalize that as an answer for everyone.
Yeah, absolutely. I think we have time for a couple more questions. So I think this one's interesting. Modified homes obviously reduce falls and associated costs and reduce the hours of care needed. Have you considered health expenses and other costs of a home as modified for safety and accessibility?
Yeah, we have not. And this is a really important point. So certainly not everybody needs to move into assisted living, and to the extent that home modifications can help people stay in their home. I mean, the cost of a place to live is a big driver of some of the assisted living costs, although with workforce costs going up, some of that calculus is changing a little bit. To be honest with you, the cost of home care is getting increasingly expensive, as we all know. But yeah, I think we need to be thinking, as Medi-Cal and other programs have, right? Home modifications can be helpful in preventing adverse events and keeping people in their homes, but they also only go so far. Not every home is going to be able to be perfectly retrofitted. Not every home has a first floor master or first floor bathroom or any of those things. And so, I think it is an important partial solution, but not likely a complete one, especially for older adults.
Yeah, thank you. So for our last question, I'm going to combine a couple that came in or attempt to. So in your 2033 forecast, will there be sort of a sufficient number of assisted living spaces and health aides to address the needs of everyone who's over 75? And I want to combine that with a question about thoughts on, what we seem to be a global shortage of workers in this area. So any thoughts on that?
Yeah, such a great question. So definitely not. Right now, there's not nearly enough assisted living units to house all of the middle income older adults, even to house all the middle income folks that we think might be interested in assisted living. But that's a private market. Part of why this study was initially funded and created by that industry. And we have seen a lot of response from the industry. Like, if there is a real middle market, I think assisted living operators will respond. So I'm less concerned about the supply side. I think the workforce issues are very, very important, right? Whether it be in a congregate setting or in-home care, we are increasingly relying on a workforce that we sort of can't identify and don't have enough of as the baby boomers age. And so I think thinking very carefully about how we both value those workers, scale those workers, and support those workers is going to be critically important. And I'm sure our panel will have some thoughts on that as well.
Absolutely. Caroline, thank you so much for that incredible presentation. And just a reminder to folks, the slides and recording will be made available after this webinar. So Caroline, thank you so much for such a comprehensive and interesting presentation. Wonderful work, and really looking forward to our reflections panel. So thank you again.
Thanks, Katie.
Great, thanks. All right. Now I'm going to turn it over to our reflections panel. We have a wonderful group of people who are going to have, I think, a really animated discussion about this data. And I think there were several questions about policy and policy solutions. So I wanted to save those really for this panel because I think that that's what Denny is going to lead us in. So it's my pleasure to introduce Denny Chan, who's a managing attorney of equity and advocacy with Justice and Aging, who's our moderator today. So Denny, please go ahead.
Great, thank you, Katie, and good afternoon, everyone. I was so happy to see all the active questions in the Q&A, and I hope that you all can keep them coming because I think our panel will really appreciate it. I want to first start off by thanking NORC, the SCAN Foundation, West Health, and Insure the Uninsured Project for organizing today's panel. I also want to thank my fellow panelists, Donna and Trisha, for joining us, and I'll let them do some intros when they do their opening remarks. I first want to start off with just a couple of my own reactions before I kick it over to Trisha and then Dr. Donna Benton for their remarks, and then we'll have some Q&A that I have prepared them for, and then we want to hear from you all. So a couple of my own reactions, first, I think it's really important to think through that obviously for those who are low income enough to qualify for Medicaid and get help paying for long-term care services, existing policies already help that population. And Trisha is going to unpack a little more about what those policy solutions currently are. But I think it's also really important to keep in mind as we think about the forgotten middle and the near dual population, that some of those current programs, the current policies that are already in place, suffer from under-enrollment, meaning that all those folks who qualify aren't actually enrolled in getting those benefits. So as we think about people who don't qualify, it's also really important to be devising solutions to get as many people enrolled as possible. I also think it's really important, one thing I was thinking about when I was listening to the presentation was really the connections to equity. And I think that there are a couple of things here that are really worth emphasizing. First is that the numbers help make the case. The numbers help illustrate that it is inequitable to treat the entire group of those who don't qualify for Medicaid as the same. Because we saw in the presentation how many of those who don't qualify for these benefit programs still face extreme economic insecurity and would be nearly bankrupted from having to pay for long-term care. In other words, many are functionally still in the same place as those who are eligible for Medicaid. Second, I think it's really important to think through that building a system of care for the forgotten middle can potentially lift everyone up. And those of you who know me know that I'm a big fan of Heather McGhee. She is a scholar and a lawyer, often speaks and writes on race equity. And in her work, she talks about this example in the civil rights movement where out of all sorts of reasons, a local neighborhood swimming pool was closed because they wanted to resist efforts to integrate. And I think that in some ways, the absence of policy solutions for the forgotten middle is similar to that closure of a swimming pool. I do not mean to suggest that these solutions don't exist because of an intention to keep people out, but I think we have to assume the systems are working as they are intended to work. In other words, if we work together on building a new swimming pool for the forgotten middle, that can lift up all groups. It also gives us a way to reimagine the current delivery system or the current swimming pool for those who are already eligible for Medicaid. And then finally, I think it's important to emphasize the numbers that we saw around who is in the forgotten middle. There can be a narrative out there that this is an overwhelmingly white, very upper middle class population. And the numbers, at least in the state of California, don't indicate that that's the case. Creating that sort of swimming pool, so to speak, would actually benefit nearly half of the people in this group as people of color. And those numbers will continue to grow. In California, that we also know that translates to a significant number of folks who are immigrants and who may also be limited English proficient. Before I turn it over to Trisha, who's going to have some of her own comments, I also want to sort of set some landscape comments around California. And so obviously coming out of the presentation, we are grappling with some real challenges. And Donna will speak to later some of the real life impact of those challenges. But California is also poised uniquely with some unique opportunities to confront these deeply seated issues. We are 2 years out of 10 years into a master plan for aging that has a renewed focus on aging, seeking to elevate aging among policymakers, public officials, and other important stakeholders. In the master plan itself is a goal called Health Reimagined. There are several really important initiatives to ensure the affordability of long-term services and supports for older Californians in the state. And we as stakeholders need to make sure that this remains a priority moving forward. In addition, The state is making huge investments into expanding Medicaid. Just this year alone, we saw 2 big improvements that are helping people get more coverage, including the expansion of Medi-Cal to undocumented older adults just back in May, followed a few months later by the increase of the Medi-Cal asset test. So both of those changes will allow more people the coverage they need to pay for these long-term services and supports by expanding the pool on the bottom end. And so while we have significant challenges, we also have significant promise. So I'm going to stop talking because I know that our panelists have a lot of wisdom and other perspectives to shine on this. I'm going to transition over to Tricia, who's going to kick us off, followed by Donna.
Thank you so much. And I love the fact that you ended with promise, because I have to say I felt a little bit intimidated by the opportunities after Caroline finished a really spectacular presentation about California. I just want to begin quickly by thanking the folks at West Health and SCAN and NORC and you, Denny, for leading the panel, and Donna, who I'm looking forward to hearing very quickly. I'm going to share my screen. I'm going to sort of build off of what we learned about in California and use some national data to talk about opportunities to make improvements for people who are just above this Medicaid level, and including the forgotten middle. So if you'll bear with me 1 second, let me share my screen. And are you seeing my screen? Can somebody say yes?
Looks great.
Great. Okay, so thank you. All right. I unfortunately can't see my screen, so I'm hoping you are seeing the first slide of Medicare premiums. Is that correct? Medicare premiums and cost sharing requirements.
It's actually the title slide, Tricia.
Okay, let me go forward. Sorry, are you seeing the next screen?
No.
No. Okay.
Go ahead. Just click on the presentation with your mouse and that might do it.
Yep, I was gonna do
And now try.
Okay,
Perfect. We can see
great.
it.
Okay. So I want to back up because we've been talking about long-term services and supports and assisted living, and those costs are daunting, but we're not quite done with healthcare yet. And I just wanted to remind everybody what it looks like for people on Medicare today. So this is mostly older adults, but people who have disabilities, starting with the Medicare deductible, which is already $1,600 for an inpatient visit, and that's start in 2023. There are premiums that are close to $2,000 in 2023, more deductibles, coinsurance. Medicare does not have a cap on out-of-pocket spending for people in traditional Medicare. There's no dental, vision, hearing, or long-term services and supports. And while the Inflation Reduction Act will make an enormous difference for people who have very high drug expenditures, there are still people who will incur up to $2,000 in drug costs, which for people with low and modest incomes is a fair amount. And those provisions don't begin to kick in until 2024 and 2025. So average out-of-pocket spending for people in traditional Medicare is greater than $6,000. It's about $6,600, and that's from a few years ago. So this is in addition to this doesn't take into account the significant long-term care costs that people may have as they grow older. And bear in mind that many people on Medicare live on limited incomes and modest savings. You saw the numbers in California. I've got some numbers here nationwide. So for example, half of all people on Medicare have an income below about $31,000 per person. I want to pause though and tell you about the disparities by race and ethnicity, because we're seeing the diversification of older adults. So while overall it's $31,000 per person for people on Medicare, median income is almost $36,000 for white people, but $23,000 for Black people, and a little bit more than $16,000 for people who are Hispanic. When we look at savings, and I know you saw numbers again from California, our national numbers are a little bit different, but I think the story is the same. half of all people on Medicare have about $82,000 in savings per person. The disparities by race and ethnicity are striking, and I don't even know what the right adjective is. So for white people, it's $130,000 in median savings, but for Black people, it's $16,850, and less for people who are Hispanic. The point here is that there are so many people on Medicare who do not have the resources to pay even the average of out-of-pocket healthcare spending of $6,600, much less some of the numbers that Caroline showed you earlier of $50,000, $75,000. And yes, people do have home equity, but not as much as you think, as you heard earlier. And there again, there are wide differences in home equity by race and ethnicity. So I think there's this assumption that people who are even the forgotten middle actually have more wealth than you think. I think that assumption isn't really correct. There are people at the very top who certainly have means, but I think there is a large body of people in the middle who struggle today to make ends meet and will certainly struggle as they grow older and encounter these costs that are beyond the reach of most. So there are programs in place, and I'm not going to talk about them in depth because I'm sure this audience knows about them, but there are programs to help people on Medicare with their premiums and cost sharing. But truthfully, people generally have to have very low incomes in order to avail themselves to these benefits. And outside of California, for example, if your income is above 100% of the federal poverty level, you cannot qualify for cost sharing assistance. It's just premium assistance, and cost sharing, as we just saw, can be quite pricey. So while these programs nationally are very helpful for people who are very, very low income, they really do not help people who are just above this level, the poverty level, or a little bit above that level. And so then people are ending up doing what they can to incur these costs, or as Tim said earlier, they're going without the care that they need. And that obviously is a concern in terms of the health of the population, or if people are foregoing trips to the doctor or not filling their prescriptions because they can't afford it. Some states, and California is one of them, have expanded the eligibility thresholds for these programs. In this map, what you see is the few states, the 6 states in DC that have raised the qualifying income eligibility level for the Medicare savings programs, for the premiums and cost sharing. And California is amongst them because California has gone up to, I think, 138% of poverty. And there are other states that have gone further. So I guess to the point, the question of what more could a state like California do? Well, California, as we'll see in a second, has lifted the asset test and will eliminate the asset test, which is, a huge benefit to low-income people. There are still people with relatively low incomes who will not qualify. So, for example, Indiana has increased its income limits to, I think, up to 185% of poverty. Connecticut, New York, other states have started to move forward or have moved forward in lifting income limits, sort of perhaps setting a course forward for California in the future. California has been a leader in terms of eliminating the asset test in a few years. And you see other states have done that as well. This is a real barrier. Denny mentioned before that it's not just making people eligible, but also connecting eligible people to their benefits. The asset test is can be a huge administrative burden for people, making it hard for them to complete the application, to get the benefits to which they're entitled. So we know that many people who are eligible for benefits are not receiving them. And I agree with you, Denny, that more work needs to be done connecting people to the benefits to which they are entitled. Shifting a little bit, I want to give you a second just to look at this slide to have a sense of how many people, what share of people below 150% of poverty and or 200% of poverty do not receive Medicare premium and cost sharing assistance. So backing up, yes, it's true that these programs are very helpful to Black and brown people who are disproportionately low income, but it is also true that people who with somewhat higher income levels, and as much as 200% of poverty, are not getting these benefits, and that covers a relatively large share of people who are Black and Hispanic. So just as one example, if you can look at the bottom portion of this slide, about 1 in 4 Black people, so the Black people are represented by the orange bar, Hispanic people are represented by the green bar. 1 in 4 with incomes below 200% of poverty are not receiving these benefits. So this is either because they're not eligible or because there's some disconnect for some reason, and I'll go through an example of what one reason might be. They are just not getting the benefits that are available to them. This next slide shows you how many people might be helped nationally, not taking into account some of the state changes that we've seen, by different policy proposals that people have talked about. So if we were to provide cost sharing assistance to people who only receive premium assistance, these are people known as SLIMBs, the specified low income Medicare beneficiaries, up to 120% of poverty, that would help 1.5 million people. It would be a huge help to this relatively small group of people because it would provide them, for example, help with their hospital deductible. Who can afford a $1,600 deductible at that income level? Or expanding eligibility up to 150% of poverty, but keeping the asset tests. And going below, moving down further, you can see how, the more that is done to lift eligibility levels, the more people who would be helped. If, for example, eligibility levels were lifted to 200% of poverty and asset tests were eliminated for the Medicare savings programs, that would help 12.3 million people. I mean, just to make an obvious point, that would come at a cost. That would come at a cost either to states if it was a state-only policy, or to the states and federal government if it was a jointly funded policy, or to Medicare itself, because there's some discussion about, well, should Medicare pay for these benefits as it does low-income subsidies under Part D, and this is right now not something that is funded by Medicare. I wanted to sort of pick up and do something similar to what Caroline did, which is talk about why this all matters. And here I am drawing on the story of a close friend. This is a friend's 80-year-old mom who signed up for Medicare late at age 75. Why? She had an unstable living situation. She didn't know to sign up for Medicare. She had language barriers, and so she just didn't. It just wasn't on her mind. Her income, her name is Susie, her Social Security income was $818 a month. But because she didn't sign up, she was hit with the Medicare Part B premium penalty. And with the Part B premium, once she did sign up, her income dropped to $478 a month, hardly enough for any older person or for any of us to live on. She didn't qualify for Medicaid or the Medicare savings programs until recently because she had $25,000 in the bank from a job that she had working evenings in a bakery. So this law, the change in California law, has been a life changer, a lifesaver for Susie, because now she can have her full Social Security check without having to pay the premium. And she also doesn't have to pay the premium penalty, and she doesn't pay the premium because she now qualifies for Medicaid. This has made an enormous difference in her ability to live comfortably, even at that income level. I will say, though, if her income was somewhat higher and just above $19,000, she wouldn't qualify because she would be above that 138% of poverty level in California. So it's sort of an income issue, and it's also a assets issue. Finally, I want to talk about some policy options that could be considered One is to expand eligibility for the Medicare Savings Program, either by lifting the income eligibility thresholds, for example, what Connecticut has done, and or eliminating or lifting the asset threshold, as in what California has done, or even better for lower income people, both. Another possibility to help people would be to waive the Medicare Part B premium penalty for late enrollment. This would be a federal policy, but this would help people who are both low income and also people who are in this forgotten middle, because if people are paying the premium penalty, and it's a lifetime premium penalty, which is a pretty onerous penalty, that can affect people at any income level. So one option might be to just waive the premium penalty for people with very low incomes. Another might be, okay, so I understand the point of a premium penalty would be to get people to sign up earlier so they don't wait till they're sick, but perhaps not make it so punitive that it's a lifetime penalty, since it's cumulative and a lifetime penalty. Another option, which would make a huge difference for people, the forgotten middle, in terms of their health expenses, would be to add an out-of-pocket cap to traditional Medicare. It's pretty extraordinary that Medicare exists today with an out-of-pocket cap only for people if they sign up for a Medicare Advantage plan, which many do, in fact, half do, but half don't. And so to help people who are on Medicare who don't choose to be in a Medicare Advantage plan, an option could be to provide financial protection so that they don't have catastrophic expenses for their Medicare covered benefits. And finally, an option might be to apply some sort of standard like the ACA did, which is to say that people on Medicare will pay no more than 8.5% of their income for Medicare premiums. You would be surprised to know how many millions and millions of people, not necessarily those who are just above the poverty level, who would benefit from that one change. So there's a lot that I think can be done just in the health sphere. And then, of course, then we move on to the broader challenges of how to finance the long-term care services and supports, including assisted living, but not just assisted living, to help all of us as we grow older. So thanks. I'll turn it over to you.
Great. Thank you, Tricia. That was a lot to unpack, but I'm sure that people are digesting it. And while people digest it, we're going to turn it over to Donna for her reflections on the presentation.
Thank you for turning it over to me. Thank you, Denny. As I watched and reviewed what we've had so far, I kept thinking about the stories that were there at the end of the people and how this is impacting families. And one of the statements that kept going over because we work so much with family caregivers is, I kept saying, what's home for people? We're talking about medical care, but we also are talking about the power of owning a home. And what does it mean when people say, oh, I have this home, it's my asset. Yes. Oh, yes. Start taking out loans on your home so that you can pay for your medical care. Well, okay, I could do that. But then what happens to that home? People for generations have built family homes, and other people have the privilege of having a family home that they can pass down to the next generation. But when we look at people and say, well, you're not part of that home. You don't get to have that privilege. You don't get to pass it on to the next generation and let your children and grandchildren benefit from something where you worked and saved and got this home and built a family in the home. So for many people, while we may say, like they said, oh, well, just move, go to a cheaper place, go to an assisted living. That's not what people want to do and how they want to use their homes. Their homes are a lifetime of memories, a lifetime of shared experiences. And we are asking, and I know this is not practical policy, but this is how people actually live, work, and still make decisions around those practical policies that happen to us. So that why aren't we paying for medicine? I don't want to give up my home. Why don't we just move? I don't want to give up my home. I don't want to go to an assisted living. And families, this is why families take care of our sick family relatives, and particularly in our ethnic communities. We know that moving someone out of the community, away from the neighbors that they've made friends with for 30, 40 years, knowing the familiarity of the neighborhood, and they know how to get to their local pharmacy, they know where the grocery store is, and within their home. As you get dementia, what do we always say? Keep things stable so that the person with dementia can navigate their environment. And then what are we asking them to do? Oh, go to a new place. What do you think that does to the person with dementia? So if we want people to age well, age in the home, and not exacerbate what we think are, we have the solution. So we're talking out of two sides of our mouth. The solution is be stable. The other solution is we're going to move you. And we can't do that with homes. And so we want our policies to reflect that. The study and what it's really, really pointing out for families and for society is that we have a clear decision to make here. If we are really committed to helping people age well in the community, if we have this commitment to having a better society and a master plan for good aging, then our policies are going to have to reflect our ability to help people stay in their home and get good medical care and help across the lifespan. The other thing is, for generations, we have within our ethnic communities been kind of forced into, with redlining and other things, we're already constricted. We already can't have our best environments. We're living more by freeways and in areas that increase our risk and hurt our health, even if we're out there trying to run and do everything. And as we have this restriction, our homes are another important part of that generational that we want to keep passing on. And so we should not, again, we have to have this ability to help people have pride, because a lot of the work, it shows that pride and keeps it moving on to the next generation and allows them to have that step up to have wealth in the next generation. We don't want everybody to have to devolve down to the lowest common denominator, and then only a privileged few get to move forward in their families. That's that's the reflection that I see in the stories, in the data. This is how it hits home. This is what I hear every day when caregivers call. And we talk about out-of-pocket cost for that older adult. For ethnic communities, the out-of-pocket cost for the family members that we're not talking about, they're contributing to that older adult's healthcare. For Latino family members, where the average out-of-pocket cost for a family might be $6,000, it's $10,000. And for African Americans, it's somewhere between $8,000 and $10,000. So families are contributing, and all we're asking back for that older adult and for the community is that we change some policies that qualify us a little bit more, that let us keep home and keep our heart and keep us from getting isolated. That's what I have to say right now before we go into questions.
Thank you, Donna. I was not expecting the connection between redlining and the forgotten middle, but I love that you made that connection for me. So I have some prepared questions for our panelists that I want to dive into, and then I also want to encourage our audience to continue to populate the Q&A with your own questions, and we'll get to them toward the end. I wanted to zoom out a little bit and talk a bit about a lot of the findings in this study really give us sort of perspective about what the future of California looks like. And we often like to think or say in California, this is our sort of state bias, is that we're a pioneer for the rest of the country. So for both of you, how do you think we should be thinking about these findings? How should we be using these findings to inform our thinking about the future of the state and the future of the rest of the country? And in particular, Donna, I was struck by that finding in the study that more and more older adults will not have children to help them with caregiving. And so if this is sort of the future that we're looking at, what do we make of that future? Either Trisha or Donna, happy to have you open it up.
Well, Donna, you had so much to say that I was just nodding. I hope you saw that I was nodding, and I was nodding thinking about the intergenerational impact, because it's not just what younger families are paying for their parents and grandparents. They're also foregoing work in order to stay home and to help their parents stay at home. They are also, it also has a health consequence for the caregivers that is intergenerational. So I just wanted to sort of nod in that direction and add to that for a second. You know, it's interesting when you think about California as a leader, and California is a leader in the sense that it has this blueprint, it has this plan, it is moving forward and being really intentional about it. And yet California is younger than a bunch of states, right? And so how exciting to see something move forward. I would love to see some of the older states, states with older populations, kind of trying to be as intentional as California is. I don't have the magic solution in terms of what exactly should be done. There are so many ways to go at the challenges that we're talking about. I almost think that any way of moving forward incrementally toward a solution, or comprehensively putting together ideas that include housing and healthcare and financial supports and social services. I've always wanted to have a one-stop shop place to go for older people, because when a health problem strikes, people don't know what to do. They don't know who to call. And so, I bet you all of us on this Zoom have some favorite ideas, but I almost think any of them and all of them are what need to happen, because we are not prepared to care for our aging populations. And I think every number that everybody saw today just makes that abundantly clear.
I think to add, to your question, Denny, about what are we doing about the changing family structure, and that people don't necessarily may not have children who are there, and adult children do make up the majority of people who are caring besides the spouse, that those are the two highest. But, the one thing that I am noticing is that people are making families of choice. And so as we look at our policies, the one thing that we can begin to do is make sure that we don't just restrict the definition of family to blood relatives, that we expand it, that we allow for family of choice, and that friends, and like we've always said, we're going to live, I have a bunch of friends who we're going to buy a place all together and we're not related by blood. You could almost look at us and tell we weren't, but we're not, and we have to be able to have that ability to have friends of choice and designate. Now, California has a few times we've expanded that in our policies, but we need to look across the board and see how are we defining and allowing people to choose the person who's going to care for them. Again, allowing for that caregiver choice.
Thank you. Yeah. The other thing that I thought, in addition to sort of thinking about the future, was reflecting on this population of the forgotten middle and the near duals. And I think some people might be surprised by the racial diversity in both of these groups. It might not surprise us as Californians as much, but sort of just thinking about who might be in that group. And so I'm wondering, Sarita opened by saying that we need to be thinking about solutions that are culturally competent, that sort of recognize the diversity of the lived experiences within this group. And I'm wondering what ideas you all have for policymakers. Like, what do you think policymakers should be keeping in mind as they develop policies to meet the needs of this increasingly diverse group of older adults and older Californians?
I just want to start with saying, if we don't get data, if we don't ask about the groups and who they are, we're not going to know what their needs are. We have to really have large systems. Some of us, they don't even collect ethnic data. They don't collect age data. They don't collect family, who's a family caregiver data, and what does it mean for them? So, that's my academic side, is I want more data consistently in these areas. Number two, for meeting this need, is that you have to go back to the community and don't just go with a negative of or coming in with, oh, you poor things. How about asking, what works for you? You've managed. What works? What would feel better for you as a community? So you have to ask the individuals, the community, for their solutions. Not just ask, listen, and incorporate, and keep it as an iterative process of discussion and putting that into policy. So.
Yeah, I would agree. I'll start with the nerdier data request. I mean, we don't have very good data about, for all the people who are in Medicare Advantage plans or special needs plans, we don't know what services they're getting. We know what plans are offering, but we actually don't know anything about the experiences of people. And I think with half of all people from communities of color now in Medicare Advantage plans, I'd like to know how well they're working. I'd like to know what services people are receiving to understand whether this major transformation of how Medicare is being delivered in our country is playing out for so many people. So, I think yes, as far as it applies to Medicare Advantage, and yes, more generally, where data just do not exist. So I thank you for raising that up. I think in addition to everything you've just said, I think we just want to make things easier for people. I'm struck with how hard it is to get information, to sign up for programs, to coordinate care, to know who to call. And I think with so many people frustrated and feeling alone as they are dealing with an older family member or someone, actually a person with disability as well. I mean, truthfully, it shouldn't be so hard to figure out how to put together the package of supports that people need, which are going to differ from one person to the next. So that would be my wish, that somehow would get translated into different policies underneath that, because that seems doable.
Don, I just want to echo something that you said around going back to the community. I mean, that's often a point that policymakers forget, or that we often don't end up doing because we think we have all the right answers, or we approach it, to your other point, from a deficit model, right? And not ask about the things that work, because so many things are working. I mean, Tricia, to your point about the challenges, it's like, I think about my now almost 90-year-old grandmother, and who's dually eligible and navigates these systems every day. And I'm like, it's both a tremendous challenge, but also she has systems to make it work for her every day. And there are a lot of things that we, I think, from a policymaking perspective, can learn from that, right? So I think both of your comments are spot on. Tricia, I want to follow up with you because I know that we have some policymakers and state officials on. And you sort of closed your remarks with a number of policy options that states and the federal government should be thinking about in terms of making this issue of affordability more affordable. How should policymakers prioritize or weigh those options in terms of both impact and cost?
So that's a great question, and that's a really difficult question. I almost think we ought to, going back to the community, find out what people really, really want in order to set priorities. This past year, past few years, there's been a lot of focus on dental, vision, and hearing. I don't know if you go back and talk to people, whether they rather have that or whether they would have premium relief, or whether they would like to have home and community-based services. I think the reality is there's a limit to resources out there, sure, but it would be great to have better information about what do people really, really want in terms of setting priorities. And then, I think the policy solution should follow from from the ground up, as you said, like listen to what people and what they are saying. And then, push as far as you can go, given the resources that are at hand, and, make incremental improvements as you try to get more done along the way.
Great, thank you. Donna, I want to ask you a question before I pick some from the Q&A in the audience. And you had started talking about this in your answer to another question, but I was wondering if you could really tease out this connection between the forgotten middle and near duals, with the connection on intergenerational poverty. How are those two things linked? You talk so much about the house and people's source of pride with the house. I'm just wondering if you can say a little bit more before we get to a Q&A in the chat.
So when policies were made early on to exclude certain populations from where they could live, which limits their assets, when policies were made early on for, say like IHSS, where you don't get to build anything into Social Security, and you're not eligible for things because we said, well, people that are doing personal care don't just need any kind of benefits, because it was mainly minority, Black and brown people. All of those things did discouraged people from being able to save, but people endure, people work. They became teachers. You went into professions, electricians and plumbers, and professions that allowed you to, when housing was affordable, rarely, to build this home. And that home is something that families, like I was thinking, my mom, I'm leaving you a home, because if everything else, I don't want you on the streets. We don't want you homeless. And so for generations, the home may be the place where people, no matter where somebody was, if the grandchild was having problems, they could go to this home. There was always a piece of property that you could go to, an extra bedroom or a living room, sofa, whatever, but you had a sense of place. And so this is what can be lost when you're asking people to use the only asset that can't be passed down from generation to generation. And so that's kind of what we see for what I see in families, and how it has come through policies that were often very much based in race, that were there so that families couldn't get ahead, lived it, you stay in poverty, and then when you try to go up, you're only forced back down.
Thank you, Donna. I knew you would do a better job articulating that than I would. But
I don't know, did he?
It does remind me of the point I was trying to make earlier, that these systems are all working as they were intended to. They were built a certain way, and oftentimes, if you can link it back far enough, there's some sort of inequity baked in from the very beginning. So we have a lot of work to do, but as I said, California also is strategically poised to confront these challenges in lots of different ways. And so I want to close by thanking our esteemed panelists, Tricia and Dr. Donna Benton, and I want to pass things back to Katie.
Thank you all for such a wonderfully moderated session, Danny, and thank you, Donna and Tricia, for such insightful thoughts and comments. I know we had a very active chat and a very active Q&A, which I think just really highlights how important it is to have these types of discussions in a policy arena. I felt like a lot of the comments were about personal experiences that we all have, and it's important to make sure that we take a look at this from a policy lens and make sure that we make this equitable for everybody. So thank you all for lifting that up and highlighting it. So thank you all. And as we said, all of the slides and presentations and recordings will be made available to the audience. So thank you all. We actually have a closing poll now that you've had a lot of time to dig in and listen to. the forgotten middles. So please go ahead and vote and take a look at that, just so that we know how to best serve you and how to bring the right information back to you. I think it's very clear that this is only really the first conversation on this topic that we need to have in California. So again, a huge thank you to the SCAN Foundation, to West Health for bringing us all together today. A big thank you to Sarita, to Tim, to Caroline, Denny, Donna, and Tricia for such engaging presentations and conversation. Thank you all, and I hope you have a great rest of the day. Bye.